Welcome, my name is Brad Chickwin, and today we're going to cover patient restraint. Disclosures, I have none. The goals for this course is after completing this course, you should be able to define what restraint is, list the risks of utilizing restraint, recognize best practice for the use of restraint in the pre-hospital setting as set by Maine EMS protocol, and then there'll be a review of chemical restraint at the end. A lot of times when you think restraint, these are the people that you believe you have to restrain because they look scary. The ones that usually get us are these ones, the ones when you don't expect. So please know that you can use restraint on anybody who needs it, not just somebody who fits the profile of being scary, because sometimes those that look very innocent are the ones that hurt us the most. So let's look at restraint of what it is in terms of patient limitation. So restraint in any method is when we limit patient movement, patient activity, or a patient's normal ability to reach parts of his or her own body. The decision to use restraint is based on the patient's current behavior, and it's also really important that no patient may ever be restrained in any way in a prone position, as a high risk of asphyxiation may occur. Definitions of restraint types. Non-violent. Restraint used to restrict a patient's movement to assist with the provision of medical care, i.e., a patient wants to remove their IV lines or grab an ET tube or pull at a PICC line or a PEG tube or a Foley. Those are non-violent reasons on why we would restrain a patient. Violent or self-destructive behavior or reasons why we would restrict patient movement is in response to severely aggressive, violent, destructive, self-destructive, or suicidal behaviors that place the patient or others in imminent danger. When it comes to these patients, these are the ones that we need to think about using commercialized approved restraints as well as incorporating chemical restraints, i.e. medications like Versed or ketamine. Please know that when you use restraints, it has risks. A restraint should only be used when less restrictive interventions are ineffective. It's clinically justified to promote healing or safety, and is warranted by a violent patient behavior that threatens the physical safety of the patient or yourself. We should never use restraint to discipline a patient, make patient care tasks more convenient for us, make a patient do something against his or her will, or retaliate against a patient who we've dealt with in the past. We need to make sure that the patient's rights and safety are protected when they are restrained. There are potential physical and psychological issues related to the use of restraints. Like I mentioned earlier, positional asphyxiation, to which when we restrain somebody typically in the prone position, we don't allow them to breathe effectively. If there's any sort of circulatory compromise, so if we put that limb restriction device on and it's too tight and they become blue, cold, it's painful to the patient, we need to make sure we loosen it and reassess the restraint's position. If there's bleeding, if a patient is found to be bleeding, we need to loosen the restraint and apply pressure to the site. If a patient starts to actively choke, remove the restraints and deal with the choking patient. And lastly, if they become unconscious, we need to remove the restraints and treat the patient because they're no longer a threat. Patients who have been placed in restraints must be on one-on-one observation until care is transferred to ED staff. This will require a second medical provider in the back during transport. At no time, whether you use physical restraint or chemical restraint, should you be alone in the back with the patient. I can't stress this enough. We should never ever restrain a patient prone or face down. This is also known as hog tying a patient. Many people have died in this position and is commonly used by law enforcement to restrain a patient who's out of control. They're doing a much better job these days of not hog tying patients or suspects like this. But if you ever come upon a patient that looks like this, you need to make sure that they are unrestrained in this position. The safest way we should be transporting any restrained patient in the back of our ambulance are one of two ways. The position on the left, where we restrain their wrists and their ankles to the stretcher so they're in the seated upright position. It's nice and tight, but it's completely restrictive. Or if they have to be handcuffed because they're that violent, they need to be laid on their side. Again, not face down. It's also not best practice to have a patient who's handcuffed behind laying supine on the stretcher. It puts a lot of unneeded stress on their hands and their shoulders and is very uncomfortable. Restraining a patient with one arm behind their head and one arm down, in theory, is best practice, but it doesn't work that well on our stretchers because when we use the commercially designed devices that we have, many of them don't get tight enough. This picture shows that posy restraint as tight as possible to the stretcher, and this patient is able to move her arm a good foot and a half. Again, our safety also is important. The arms over the head positioning is both antiquated and proven to be ineffective in the acute care setting. It is extremely dangerous for the patient to lay them supine with their arms and legs pinned to the stretcher with their arms above their head as seen in the picture. It can cause them become short of breath. It's very difficult to breathe and it leaves them completely exposed. It's okay if you need to do this for your scene safety initially until you can get more help to keep the patient safe, but it is not appropriate to transport a patient supine with their arms above their head like this. Typically, the best practice to restrain a patient with one arm above their head and one arm to their side is when they use stretchers in psychiatric hospitals designed for proper positioning. You will find that most EMS stretchers will not allow for it to be safe for us to restrain a patient's arm above their head and one arm down by their side. It will work the best for us if we restrain both of their arms down by their side and both of their feet to the stretcher at the ankles. The whole goal of restraint is to gain control over someone by the least amount of force possible. If you need to go hands-on with a patient, a combination of both chemical and physical restraint is the safest option both for you and your patient. If physical restraint is utilized, it is best practice to always have a second EMS provider during transport, and his or her only responsibility is to continually monitor the patient's airway status as well as the effectiveness of the applied restraints. These secondary providers need to be licensed EMS providers. A law enforcement officer does not count as the second person in the back. Once we restrain our patients, because it's deemed necessary for the safety of the patient and ourselves, it is really important to make sure you clearly document in your PCR narrative a variety of things. 1. What actions or behaviors or conditions that indicated the initial and continued use of restraint. 2nd, any considerations or failures of non-physical interventions or alternatives that you used before you decided to go hands-on. What you did in the back of the ambulance for continued patient monitoring, assessment, and reassessment. Any significant changes in the patient's condition, meaning if they become cooperative or they go unresponsive. Who is responsible for the continuous monitoring of the patient's restraints during transport? So this would be where you clearly document provider X was continually monitoring the airway. Airway monitoring included lung sounds, respiratory effort, SpO2, end-tidal CO2, for example. Also monitoring that the restraints were on properly, that they were tight, you had good CSMs, so circulation, sensation, motor function of the hands and feet, so you didn't have any blue or purple fingers or toes. Typically, an appropriately placed restraint, you can probably get one, if not two fingers underneath it. And then, as part of our protocol, who and when medical control was contacted, because we need to let medical control know that we have a restrained patient coming, both chemically and or physically, so that way they can prepare their team in the ER as well as have security on standby. So let's take a peek at Maine EMS treatment protocols. First and foremost, in certain limited situations, when a patient poses a significant danger to self or others, it is appropriate to restrain patients involuntarily. We need to make sure we use physical restraint as last resort, preferably with the assistance of local law enforcement. Once a decision is made to restrain a patient, the least restrictive restraint reasonable should be implemented, and the patient should remain restrained until arrival at the ER, unless it interferes with delivery of medical care. Only commercially available soft restraints are approved by Maine EMS to be utilized. This brings into discussion other ways to restrain a patient that we may have been taught in the past that does not involve Maine EMS approved commercially designed devices. Meaning, we are not allowed to use ropes and do handcuff knots. We should not be using duct tape or any sort of tape to tie their extremities down to the stretcher, nor should we be using triangular bandages or pillowcases or any sort of torn sheets or towels to restrain their hands down either. Why it's important not to use any of those non-approved methods is because if you go to court, your decision to use something other than a commercialized device that was available to you at the time of the incident that ended up harming your patient will then be used against you when they compare any other provider's reasonable treatment for the same case. You do not want to be on the receiving end of a lawsuit to which EMS provider after EMS provider goes on the stand and explains how they use approved devices when restraining a patient when you decided to make something up because it was easier or more convenient. Please, please protect yourself. Moving through the protocol, we start off with the most basic way to deal with these patients. So the first and foremost, before we go hands-on, we need to make sure that we rule out any medical issues that we can fix, i.e. something like hypoxia, hypoglycemia, an overdose. You need to request law enforcement if you've done so already. Request ALS. Again, ALS is defined as a paramedic. Attempt to de-escalate using a calm, honest voice, a tone that's not confrontational, and avoid eye contact. And then again, before you decide to go hands-on, most importantly, make sure you have the muscle or the hands around you so that you can do it safely. So once you've decided to go hands-on, you need to make sure you restrain patients in a lateral, so on their side or supine position. Never, ever, ever leave a patient prone or hog-tied. That's when their hands and feet are tied behind them. And all applied restraints must be easily removed should a medical emergency occur. We should never place any sort of objects on top of patients to restrain them. That meaning using a KED on top of the patient to restrain them to the stretcher, or using a long board or another person. It does a really good job in this protocol highlighting that restrained patients require one-on-one observation by EMS personnel in continuous cardiac pulse ox and waveform capnography, if able to do so, again, if they're cooperative enough to do that. But again, one-on-one observation is required. And then we need to contact online medical control as soon as possible and when it's safe for us to do so, to give them a heads up. Protocol moves on to give us a CYA section, meaning our documentation. As I just discussed before, we need to make sure we document any de-escalation techniques we use prior to going physical restraints, document the type of the restraints used, how they were applied, when they were applied, why they were applied, the agency and the individual who applied the restraints. So was it the cops with handcuffs, or was it us with what we had in the back of the ambulance? frequent vital signs, CSM checks, and then education provided the patient in the time online medical control was notified. Education provided the patient is sometimes they might be altered and keep on asking, why are you doing this to me? I didn't do anything wrong. You need to explain to them that they're being restrained for their safety or because of X, Y, and Z that they did. Just be honest and upfront with them. These are high liability calls because there's a high likelihood that this may end up going to court, especially if law enforcement was involved. FYIs for these sort of cases, we need to make sure that if a restraint is applied by law enforcement, that it requires them to stay in the back of the ambulance at all times, so that way there, if something happens, the handcuffs can be removed quickly. Restrained patients should not be moved in a stair chair as they become violent and the stair chair becomes very difficult to handle. So please don't put your out of control patients in a stair chair. And then we need to make sure that we send our restrained patients to the nearest appropriate emergency department for care. So let's talk about different types of soft restraint devices. Posey soft restraints are one of the most widely used soft restraints in the healthcare setting due to the ease of its application and the dual quick release clips. When applied properly to the stretcher and the patient, you'll notice that the hands of this patient are secured tightly by the hips and ankles securely at the bottom of the stretcher. Looking at these devices, first you should notice the quick clip release on the portion that's attached to the stretcher. The second quick release clip is on the extremity itself, whether it's the wrist or the ankle. Note the reverse buckle application of the restraint. This does not allow the strap to slip through the clip and loosen up if the patient tries to fight. Some services have opted to be proactive and mark where the straps should be attached to the stretcher. Looking at this stretcher here, there is silver tape on where the initial application of the extremity Posey strap should go. Proper securing points on the stretcher where that tape was, you'll notice, are where those straps are applied. It is not attached to anything that's adjustable, like the arm railings or the IV pole, because those would easily snap if the patient became combative. Due to infrequency of restraint use, the stretcher being exposed to a variety of weather conditions, and the repetitive daily deconning of the stretcher, it is not advised or recommended to preset the restraints on the stretcher due to the potential of product compromise at time of use. It is more effective to constantly train on these devices so that way there, when you have to use them, muscle memory kicks in. In addition to physical restraint, we can also use medications. So pharmacological management is strongly recommended when it comes to restraining of a patient. We don't have to be a black belt in karate because we as EMS clinicians, as paramedics, have earned our black belt in pharmacodynamics. So let's go over chemical restraint as it pertains to ketamine and Versed. And notice it's an IM injection. Let's review the pearls for both midazolam, also known as Versed, and ketamine. So let's start with midazolam. Patients with underlying medical conditions such as COPD, CHF, and CAD, as well as patients older than 60 years of age, are more likely to suffer adverse effects from Versed. For these patient populations, consider lower dosages. Using Versed in our patients, we always need to make sure that we monitor their respiratory effort because there is a chance of respiratory depression, apnea, or arrest. We should always monitor our patients with end-tidal CO2 or an SpO2 readings. Administration for Versed in these type of cases should always be a deep IM injection into a large muscle. A large muscle is typically the quad, the gluteus maximus, and if you have to, you can use a deltoid. Let's look at ketamine. Anytime you give ketamine for these type of patients, we need to make sure that we document our patient's altered mental status score, also known as AMSS, in the run report. We'll cover that in later slides. Any patient with an AMSS score less than 4 may be more likely to require airway management when receiving ketamine. Therefore, ketamine is only used if the patient is suffering from a hyperactive delirium and severe agitation, as measured as an AMSS score of 4. Maine EMS services will be stocking 100 milligrams per ml concentration to accommodate this wide dose range of the protocol. Overdoses may lead to panic attacks and aggressive behavior. Rarely does it cause seizures, increase ICP, or put them into cardiac arrest. Again, administration is an IM deep injection into a large muscle mass for these. Let's discuss the pearls for hyperactive delirium with severe agitation. Agitation by definition is excessive, purposeless, cognitive, and motor activity or restlessness, usually associated in a state of tension or anxiety. Hyperactive delirium with severe agitation is a subcategory of agitation with the potential for higher morbidity and mortality. It is defined by a patient presenting with the following constellation of symptoms with frequency. So exceptional or abnormal pain tolerance, so they're superhuman, increased respiratory rate, tactile hyperthermia, so usually they're super sweaty, unusual strength, so these are the folks that are throwing around cops like they weigh 22 pounds, police non-compliance, so this is where it takes 4, 5, 6, 10 cops to restrain them, lack of time against restraint, so this is kind of the Hulk phenomena, where they are being restrained but kind of still able to fight when you and I would be pinned to the ground. Inappropriate clothing for environmental temperature. A lot of times these patients are either naked or shirtless and it's cold outside. Violent or paranoid behavior. Rapid development of symptoms, so they might just rifle through all the symptoms we just went over. And then rapidly fluctuating from periods of calmness and then into delirium. Please remember that patients who are in a postictal state are not considered to be in a hyperactive delirium with severe agitation and should not be given ketamine. And patients should not receive both Versed and ketamine due to the concerns for potential addictive effects and respiratory depression. Looking at the protocol for hyperactive delirium with severe agitation, this is our assessment tool that we use for all of our combative patients. It's called the Altered Mental Status Scale, or AMSS. It's a scale that goes from a +4 down to -4. The higher the score, the more likelihood we're going to give medications for chemical restraint. The lower the score, it's more of a medical emergency. We need to make sure we treat them medically without any sort of restraint or chemical sedation. In order to be a +4, so this is when we would use our ketamine, they need to be combative, very violent, and out of control, have loud outbursts, be very agitated, and their eyes are normal. When you get into the +1, +2, +3 realm, this is where we're not typically using ketamine, but we're using Versed. And then when they're 0, they're baseline. And then -1, -2, -3, -4, this is when there's typically some sort of medical emergency that's going on that we would not use sedation. When we have to decide whether we medicate or not, we use our assessment score from the AMSS scale, Altered Mental Status Scale, to determine what our treatment is going to be. If we observe the patient and they're alert, they're restless, they're agitated, combative, they typically fall somewhere in the 0 to +4 range. If we say the patient's name in a gentle tone of voice and ask the patient to open their eyes, usually fall in the -1 realm score, which they won't need any sort of sedation or restraint. And if they're not responsive to voice, we need to continue with routine EMS care because they're typically painful stimuli are unresponsive. So again, that is not appropriate for us to restrain or use chemical restraint. Going back to the protocol, as a paramedic, if we have determined that their altered mental status score, AMSS score, is a 1, 2, or 3, we can consider the use of Versed 4 to 10 milligrams IM for the patient/EMS clinician safety and patient comfort. The first dose should be based on patient size, age, and circumstances of agitation. So again, we're allowed to give a nice deep IM injection, not IV, IM, for an adult 4 to 10 milligrams. And as a pediatrics considered 10 years or older, we would give 0.1 milligram per kilogram IM to a max of 10 milligrams. For a child that's less than 10 years of age, we need to contact online medical control for administration. As it pertains to the adult and Versed use, it is best practice to only have to inject them once. So if you're on the cusp on whether or not you want to give the minimum dose or the maximum dose, and their presentation warrants the maximum dose, please go ahead and give them the full 10 milligrams. So that way there you don't give them 4, have it not work, and then have to repeat with another 6. As paramedics, if the AMSS score is +4, we can consider still using Versed, or we have the opportunity to give ketamine. The dose for ketamine is 4 milligrams a kilogram IM with a max dose of 500. We should not be using ketamine on patients at greater than 65 years of age. Please use Versed for those patients. For pediatric patients with ketamine, it's 4 milligrams a kilogram IM. For children less than 10, call an online medical control. I like this slide because I was able to pull out that +4 score of the AMSS scale, altered mental status scale. So if a patient is combative, very violent, out of control, they have loud outbursts, their facial expression, they're agitated, their eyes are normal, we can go ahead and give ketamine for this. If you notice the weight-based dosing for adults in ketamine, it's a lot, meaning we carry 500 milligrams of ketamine on the ambulances. If you have a patient who weighs in the range of 200 pounds, you're looking at 350 milligrams. If you have somebody who's greater than 275 pounds, you're giving them the whole truck, all 500 milligrams. It's important to make sure you dose appropriately because we want to give them a dissociative effect, meaning we give them ketamine, it gives them an out-of-body experience to which it doesn't typically alter any of their vital signs, but they kind of detach from their body psychologically, and most patients who have been given this dose, when you talk to them later, say it's like they were looking at their body but they couldn't move it. When we underdose these patients, that's when we become in trouble because we get them stuck between that dissociative effect and being, quote, stuck in their body, and sometimes they can become very, very psychotic and actually makes them worse. So if you need to give ketamine for a patient, please make sure you give them enough of the medication and not underdose them. From a medical director from Central Maine Medical Center, Dr. Anthony Regis, great guy. He believes that he would emphasize that once physical restraints have been employed, to remember that Versed or ketamine IM can then be given in addition. Of course, continued patient monitoring and frequent reassessment is needed. What he's trying to say here is it's okay to use both, and it's appropriate to use both. It's safer for the patient and it's safer for you to, if you're going to have to restrain them, to also give them chemical sedation as well, chemical restraints. So that way they don't separate a shoulder or fracture a wrist because they are fighting you so much. Sometimes just giving them that ketamine or Versed, depending on where they fall on the AMSS scale, calms them out enough so we can get them safely without any further damage. Thank you everyone for taking this program. I hope you took something away from this. As always, if you have any other questions, please send me an email at the email listed there. Be safe out in the field, and thank you for attending.